Hello, it's my absolute pleasure to be delivering this webinar with you today. I'm going to be discussing with you where adjunctive therapy fits in the management of non-healing lower limb wounds. But in addition to that, I'd like to share with you some real-life patient examples of the benefits of one such therapy in my practice area. Now, we're all aware of the burden of wounds, aren't we? I think there is lots of data out there that encompasses wounds that are hard to heal and the burden to healthcare providers such as the NHS, to you as clinicians with your time, and really to the cost to the organisation, as I've just said. Now, overall, annually to the NHS, wound care costs about 8.3 billion. But can I just say that 5.6 billion of that cost is actually to managing wounds. So we're not talking healing the wounds, we're talking managing unhealed wounds, which basically is managing the signs and symptoms of the wound and not actually treating them successfully. But to me, the biggest impact is to the burden to the patients. I'm sure every day you see this in practice, but to really be seeing this massive impact on the patient's quality of life of living with a wound. You know, the impacts are physical. So you may, I'm not going to list everything that's on the screen, but you may see your patients with reduced mobility because of the wound. They'll be not sleeping well. If they're not sleeping well, they probably won't feel like eating. So nutritionally, they might become depleted of vital nutrients for wound healing. They get pain, they become socially isolated because of embarrassment, they become dependent on maybe family members, or they become isolated because of loss of work or not being able to work. Emotionally, to me, though, massive stress and anxiety, even leading to clinical depression. And I myself have referred patients for counselling, patients with chronic non-healing wounds. I can't ever imagine living with a wound longer than 4 weeks, let alone 4 months or a year. And some of that emotional trauma is the fact that they feel that the wound may never heal, that they may lose a limb. It's just massive. And I could talk to you for an hour about the burden to our patients, but I think it's still something that is sometimes not fully appreciated. And there's lots of surveys, or there's certainly been an international survey looking at hard to heal wounds. And what surprised me is that survey found that wounds, irrespectively whether they were hard to heal or whether they were improving, were basically treated the same. And that worries me worries me a lot, should I say, especially in 2024 around wound healing. It also shows that venous leg ulcers, we can use what we call a response indicator. So if a wound is improving, so you've got a patient with a venous leg ulcer, the wound is improving, that's a reliable predictor that you're on the right treatment pathway or you're not. And that's what we should be considering as well, because if at 4 weeks, let's say, you're not seeing a wound improvement or wound reduction in size by 40%, then you should be stopping and looking at the predictor to say, I don't think this is moving along the healing trajectory as we would like. Therefore, we need to reassess, review, and maybe rethink the treatment for that patient's wound. Now, we know, again, there's a plethora of information and evidence around characteristics of delayed healing. Some of those are on your screen, as you can see, and we can see that wound to the patient's lower limb that can be very debilitating. So some of those characteristics are the ulcer is large in size, or it's increasing in size. Let's not forget that. The longevity of that wound, how long has the patient had that wound for? The longer the patient's had a non-healing wound, the harder or the higher the risk factors of delayed wound healing there is. Was the previous history of ulceration, venous abnormalities, which again may delay the wound from healing successfully, especially if there's a lack of hygiene or what we call full therapeutic compression. poor nutrition, as I've just mentioned, and increased age. So you can see those characteristics that can help you to predict a patient's wound may, even when you've only just met them, may go on to be slow to heal. And predictors are a good way of indicating that. Now, a paper that was written and a pathway that was written by Vowden and Vowden was really interesting when I read it. And it's very clever how it takes you through your patient's journey to see and help you to decide as a clinician, where does adjunctive therapy fit? And I think that's so important that we use these types of pathway to help our clinical decision making. And I know we do in our practice. So let's, for example, you see a patient who has your first initial assessment. They have a non-healing lower limb wound. You may diagnose that it's a venous leg ulcer, but it's certainly a lower leg wound that's non-healing. You'll examine the wound bed to see that it may have high areas of high proportions, of necrotic sloughy tissue. You may use your leg ulcer infection pathway to see if you need to manage that. So we do that initial assessment, don't we? And we put in, particularly if there's a diagnosis of that venous disease, that we'll put in that standard evidence-based compression therapy, that full therapeutic compression, alongside appropriate treatment of the wound bed, of the patient's pain, and all those other factors. So from your initial assessment, normally just 3 to 4 weeks, you'll be reviewing you'll be reviewing the limb and the patient, all those other factors. Now, if the wound, I'm going to take you through the scenario of a patient where you put into standard compression therapy and good wound management, but the wound itself is not improving and it's not certainly reducing in size. It's at that point you really need your early intervention and intervention and introduction of that therapy, that adjunctive therapy, because what we don't want to do is to wait weeks and weeks or months and months before we consider its appropriate use. Okay, what I will say though is if I assess a patient whose factors, delayed wound healing factors that we've just discussed, are quite high, so for instance they may have multiple comorbidities, they may have had the ulcer for over 6 months, the ulcer's very large in size, at that point, so that early onset, I may introduce that adjunctive therapy from first onset. So there's those patients that you're reviewing who are not improving, and those patients with those high risk factors of non-healing, where I would consider early intervention with that adjunctive therapy. And with that therapy, when that's introduced, again, you're reviewing at that 4-week progress to see if the healing is moving along as expected, and helps you to make those decisions if it is or it. So what are adjunctive therapies? What are some of the adjunctive therapies available to you? I'm not going to list them all or read them all out. One in particular, though, is the neuromuscular electrostimulation therapy. And this is an area of adjunctive therapy that we have introduced into our own workplace on the Isle of Wight. And that's what I'll be sharing with you, of how that adjunctive therapy helped to benefit our patients in real life. So what is neuromuscular electrostimulation? The device that we implemented was the Gecko device, and what it is an easy to use. It's powered by a battery, so there are no wires. It's worn just below the knee, so you can see that in the image on your screen, and it's worn for 12 hours a day. Okay, and what this does is it stimulates, and I've got a video that will show you this in a few minutes. It stimulates the common perineal nerve. Okay, so what that does then is gives that electric pulse through that nerve every second. That gentle, and it is a gentle stimulation, causes the muscle in the calf and the foot. So we've got foot pump and the calf pump muscles contracting, and that results in increased venous flow back to the heart, but also increases arterial flow and the microcirculatory blood flow. And I must emphasize there, it isn't just the improvement in the increased venous return, it's also arterial flow and the microcirculatory blood flow, which is so important in your patients with certain comorbidities or hard to heal wounds. There's 10 device settings, so it can be adjusted to the patient's requirements, but as long as they've got that, you'll see a visible foot twitch. Again, we can talk about this later in the Q&A, that the patient can visually see, but it also means that we're making sure the patients are comfortable with that stimulation as well. I'd like now to show you a video of the Gecko device actually in action. So what about the evidence? You know, we talk a lot about evidence and what about the Gecko evidence in practice? There's another video I'm going to be sharing with you, and what the video is showing is the blood flow comparison. So it's actually showing you the blood flow with the actual Gecko device switched off, and it's showing the blood flow in the veins and the arteries. And as you can see, there's of course blood flow through the veins and a little bit through the arteries, but what I want to try and show you is the comparison when the actual stimulation and the Gecko is switched on and we're getting that stimulation. You can see the significant increase just from the screens and the video of the arterial supply and the venous supply. And let's not forget as well that microcirculation. I mean, we're talking a real significant increase in flow. What we're going to be showing you is the comparison of when the Gecko device is not activated and when it is activated. And at 15 to 30 seconds, even though the Gecko device is active, but before that calf and foot twitch is achieved, we're still getting 100 to 200% increase in microcirculatory flux. Now at 30 to 45 seconds, the Gecko device is now at a higher setting, and we're getting that calf and foot twitch that we want to achieve. We're getting 1,000% increase in microcirculatory flux. Now, what that means in clinical practice for your patients means the increased blood flow means increased oxygen. Increased oxygen means increased essential nutrients. Essential nutrients, not only blood flow to the limb, but essential nutrients to the skin and to the wound itself. So let's remember the skin as well. We need to keep the skin healthy, but we want those essential nutrients also to arrive at the wound bed and promote total wound closure. And that is our aim. So there was an RCT undertaken comparing a cohort of patients with venous leg ulcers receiving a standard treatment and a cohort of patients receiving compression therapy standard treatment and the Gecko system as in addition. And the results were phenomenal. 42% of the wounds of the patients in the cohort with the Gecko applied healed completely, compared to 27% in the standard of care alone group. And that's a considerable increase, isn't it? And I know what treatment I would like to have if I had a non-healing venous leg ulcer. What was also important, that I'll be honest, when I first looked at the system, I wondered if my patients, our patients, they're all our patients, would be happy with that sensation, or would they concord with the Gecko itself. But from a practical point of view and professional and personal, they absolutely adhered fully to it. And the RCT goes along with what we found, that 94.1% of the people within the Gecko group actually adhered. They were so concordant to the system, so it didn't actually interfere with their quality of life. And in fact, I'm going to show you in our own studies how it significantly improved their quality of life as well. So, you know, in just a 4-week period, the studies showed that they more than doubled the rate of healing. And I think, you know, in clinical practice, this is what we want to hear. So what I will ask you though is, we're fully aware now of the benefits of adjunctive therapies, particularly this type of therapy in the gecko. We've talked about that. We've talked about how it works. We talked how it improves the blood flow through three blood systems, and what that means to wound healing and to your patients. It's so important that we use a really good pathway that helps you and other clinicians to select the patients who are right for that adjunctive therapy. So what I will ask you is, when you're tomorrow in practice, in fact, I'll do a little pledge to you. Just think of your patients in practice, and maybe tomorrow, or when you're next at work, think of your patients. Does any of your patients have a VLU that's not really on a positive healing trajectory? They're not responding to any standards of care. Or do they have a venous leg ulcer that's static? You know, and we hear it say that, don't we? That wound is stuck, and they've got no significant signs of healing, no signs of revascularization of the wound bed. Or a patient that's unable to tolerate full therapeutic compression or compression at all. And what I will also say is a patient that has a high number of risk factors that will lead to significant delayed wound healing. And I think that's important we add that there as well. Also, a patient that can fit, remove the device, or have it, or family member that can do that. And I will say it's so simple to fit. But equally, they don't have a suspected or confirmed DVT. Now, I think I can honestly say that most of you in this audience, or your colleagues that you work with, can say yes to that you do have the right patients, that you could be using this device alongside your compression therapy, or in some of our patients I'm sharing with you, no compression at all. And it will significantly help to move them along, move the wound along, should I say, along to full healing, and certainly improve their quality of life. So the key messages to me, well, I think the key messages for all of us, as I've just said, you know, we've looked at the benefits, we've looked at the evidence, and I will always say I feel very strongly about using evidence in practice. You know, we have to use evidence-based treatments, and it's so important that we look at that evidence, and that's what we've done. If we're getting results like this, if we're seeing that evidence, then why are we waiting? Why are we waiting for patients? You know, it's not the patient's fault. It's not anybody's fault. It's just the wound is not moving along that trajectory. So why are we waiting? Why are we waiting months, even years? And one of my case studies I'll share with you is a patient who's had an ulcer for 20 years. Why are we waiting? I need to ask you that. So let's not delay. Let's not delay at all. Let's initiate that adjunctive therapy where it's appropriate for your patients. Let's shorten their healing times, or shorten the wound healing times. Let's improve your patient's quality of life whilst reducing the burden of wound care in your practice. And let's tick all of those boxes. And I'd like to share with you now some of those, you know, real life stories, and I'm a clinician through and through. Tomorrow I'll be in practice, tomorrow I'll be seeing patients, and it's the patient story that always makes me listen about what we should and shouldn't be doing. So I'm going to share some of the real life examples with you, and I've got 3 case studies. They're not my case studies, they're actually my colleague's case studies, Stuart, who works within the tissue viability team. But I equally have some of the patients I've used Gecko on, and we've just selected 3 to share with you today. So this is a gentleman with a non-healing mixed etiology. So he's had this wound leg ulcer for over 4 years. So we have chosen some real, you know, patients aren't difficult, the situation is difficult. He's got many factors that is going to delay or hinder the wound healing process. He's got peripheral arterial disease, he's got diabetes, hypertension, so he's got significant comorbidities that are going to affect wound healing and make it hard to heal. Most significantly, he had a pain score of 7 out of 10, 10 being the highest, and he was taking regular Oromorph and other analgesia. He didn't and couldn't have any therapeutic compression, and that was also due to pain as well. He wore the device for 12 hours per day, as directed, over 7 days, alongside his current treatment. Nothing else changed within that plan. But only after 1 week, the skin, so I want to emphasize here, the wound improved, it started to reduce in size. We're talking 1 week, okay? But the skin started to improve. Now, I think that was two things. One, we were achieving more oxygen nutrients, not just to the wound, but to the skin. But the system, because it's improving venous return as well, exudate levels began to decrease. But most importantly, this in just 1 week, this gentleman's pain had reduced significantly. And so, you know, that speaks volumes about this gentleman's quality of life. He continued to go on and is almost healed. I'd love to say he's healed. He's not, but after 4 years of non-healing, he's on the right trajectory to healing, and his quality of life has significantly improved. We have a 69-year-old male now, and the story here is the assessment. So let me take you back to that flow chart, that pathway. So he's got a non-healing venous leg ulcer. Now, on and off, he'd had this history of venous leg ulceration for 20 years, and he'd been self-managing for 14 years. I cannot even begin to imagine the impact on him. But let's remember, what's the impact on his family? You know, what's the impact on those around him? The impact on is just daily activities and being dependent now on his wife, being dependent on his family, his loss of role as you know, as a husband or a father or a grandfather. It's massive impact on this gentleman. He's got a large wound, and again, remember that assessment part of the larger the wound, the more difficulties it might be in achieving full wound healing. It's heavily exuding. And he got some infection as well. Again, he wore the gecko for 12 hours. It was explained to him he was suitable. He was assessed as suitable for implementing the device using our pathway. It was worn for 12 hours, 7 days a week. Now, the dressing regime, he had an antimicrobial on before the implementation of the gecko, and that continued. So nothing else was changed there. And he continued with his compression wrap because he was supported self-care. But in 1 week, again, what I want to say is that there was significant improvement in his pain, in the condition of the skin, and after 28 days, significant decrease in size, and at 8 weeks, full wound closure. And you can imagine then how elated he was. He could return to not being dependent on others, his own self-esteem, you know, his low moods and depression was lifted. I can keep talking for the next 30 minutes about the positive impact. What it means, clinicians, not just us, the district nursing teams, the practice nurses. You know, one, staff morale was elated. You know, staff morale was much improved, and reduction in clinical visits, reduction in dressings, reduction in the burden, as all the burden to the organisation, the burden to clinicians, but most importantly, the burden to the patient. And finally, this is a 46-year-old lady with a non-healing painful ulcer, and see that 5-month history that she was actually self-caring. She was buying things. It was an insect bite. She was buying things over the counter. So for 5 months, she'd been doing this. Now, we might argue, oh, she should have, you know, come for help sooner. But unfortunately, there's quite a lot of patients that do this. They think it's just a bite. She'd been signed off from work due to pain, infections, and inability to undertake her role. Massive impact on her income, impact on the rest of the family, which you don't need me to really elaborate on. It's a very painful wound. It was sloughy, little bit of granulation, but her pain level was 9 out of 10. Sleep deprivation, not eating, nutritionally depleted, all those factors because of her pain. We continued on a standard management treatment regime, and the gecko was introduced as prior with the other patients. But after 1 week, for me, it was the pain reduction. It was from 9 out of 10 to 3 out of 10. Can you imagine what that meant to her? She was sleeping better. She was actually now sharing no, it sounds daft, but sharing a bedroom back with her husband because she wasn't sleeping there because of the pain disrupting him, the fear of him knocking it, all those other factors. You know, her relationship was being affected. She could go back to being a mum. She could go back to work, even though the wound was improving. Because the pain had improved and she could see that the wound was healing, she could start to plan going back to work. And after 6 weeks, the wound was fully healed and she returned to work, which again is significant for her and significant for us as clinicians. So I'd like to thank you for taking the time out of your busy schedules to listen and learn about adjunctive therapy and the Gecko therapy, that the Gecko device that we introduced into our clinical practice. I'm so glad I've had the opportunity to share the real life clinical experiences, both from the clinician's perspective, but most importantly, the patient's perspective. And I know you've had the opportunity to drop some questions into the chat box. So we're now going to hopefully answer some of the questions that you have raised. Thank you.